Good evening, everyone, and welcome to the webinar on recent advances in HER2 low breast cancer management. It gives me great pleasure to invite our program director, Dr. Krishna Chaitanya, medical oncologist from Hyderabad, to give the opening remarks. Over to you, sir.
Yeah, good evening, everyone. And I would like to thank the organizers for giving me the opportunity. And today we are going to discuss the recent advances in HER2 low breast cancer. Dr. AVS Suresh, sir, who doesn't need any introduction in our community, and he is multi-talented, and his contributions span across various fields.
Is it? Am I losing you or is my?
And he'll be discussing.
Sir, Chaitanya, sir, I think there is.
That's okay. We can hear.
Emergence of the HER2 low metastatic breast cancer management landscape. So we can hear you.
It seems like Dr. Krishna has a little bit of network issues at his end. I would like to invite Dr. AVS Suresh to give the first talk. Over to you, sir.
Sure. Thank you. Please, can you share the slides? So this is a very interesting topic that we're going to speak today. In between, I may, on my mobile, so you may see a small glitch. Am I audible and visible? Ma'am, I need to see the. No, yet to see the screen. Clear. Good, great. So can you share me the actual presentation, please? So we all know that HER2 positive is either 3+, and if it is 2+, we always used to go for the fish. That's what is the commonest thing that we used to do. Okay, but the world has entirely changed. This is because we have antibody drug conjugates. We have one drug which was available for almost a decade now, that is called TDM1. But the actual game changers are the next two things which we are going to cover now. Next, please. So we're going to tell about the historical, why the HER2 is 0, 1, 2, 3. Why not positive and negative like ERP? That is what we're going to discuss. Structure, how does this ADCs actually look and actually function? In HER2 positive, beyond second line, we have limited things, especially when HER2 is negative. Hormone receptor positive, HER2 negative, after second line is always challenged. They do good in the beginning, but when they fail really bad. So this is what we're going to discuss. And finally, TNBC, can we do some dent into the existing numbers in terms of improving the survival? And finally, I'm going to summarize. Next, please. The historical classification, next, please. If you look at it, this is next, please. If you look at it, it is 0, 1, 2. That's what we do. If in 2, we split into, we do ISH, either dish or fish. And then if it is positive, you call hyperamplification and then go for the trastuzumab like drugs. If it is 3+, it is straight away. Next, please. This happened because of this particular study, which was developed on the aqua-based protein expressions. So what they do is they try to analyze how much human epidermal growth factor 2 is expressed. There is mu is something related to the mice gene. So mu, let's keep it aside. That is HER2 was classified into either 0 or it is expressed or amplified. But if you actually slice and dice this slide, then you understand that even 1+ and 2+ are also having the receptors on them, though the expression is not significant. So the dilution matters here. 1:4000 versus 1:250 have entirely different pictures that is going to be coming out in a different way. Next, please. So this is what actually historically happens. First line, in HER2 hormone receptor positive things, you have up to 28 months of overall survival and almost 8 months of progression-free survival. Second line, it falls down to half, that is almost 14 months. Again, OH falls to half. Third line, again another half, that is 6 to 8 months. That's the classic behavior of any further lines. So we are in need of some drugs that is going to make significant difference in these lines. Next, please. So what to choose, how to choose? If it is HER2 positive, we can always choose. That is easy. But if it is HER2 negative, then the pink one, which are going in the lower part of this slide, is that true game changer. That is IHC 1 plus and 2 plus also are coming slowly into the picture of the treatable category with the druggable targets. That's what we are going to express and explain today. Next, please. So if you look at how much percentage of patients are going to make dent into it, 2/3. That means every 2 of this particular treatment, prolonging either PFS or OS in these patients. If you look at HER2 negative, otherwise the older classification,
Dr. Suresh, can you hear us?
so I actually, and I'm getting a call from the hospital, so
Okay,
sorry
sorry.
for that. Yeah, so in between, I have a sick patient, so I may be taking the calls, please. So I'm still in the hospital, so I'm logging from mobile. Excuse me for that. Okay, so the 2/3 of the patients, you can actually make a good difference in their lives and survivals. That's what is a beauty of doing the understanding they have to in a better way. That is 1 plus and 2 plus are not 0. They are actually 1 plus and 2 plus. Right, next, please. So if you look into the older data, try to understand whether they really did different compared to others, the answer is yes. 1 plus and 2 plus are not as bad as 0. So that gives us extra confidence to conclude that we have to treat 1 plus and 2 plus differently from 0 or 3 plus. So what and how is what we are going to discuss in the next feature. The OS and PFS for the 1 plus and 2 plus are different from HER2 0. So this is what we went to IHC. I'm just talking about. This is what I need to emphasize on that. Next, please. So is it what I am saying? No. The 2022 ASCO guidelines also says the same based upon one of the landmark trials. Right? So what is this landmark trial and what is this molecule? This molecule is called trastuzumab deruxtecan. We call it shortly T-Dxd. Right? So this particular thing has made a significant difference in the guidelines as well. Next, please. This prior to the Destiny Breath 04, there was no clinical implications of the IHC 1 plus versus 0. But after this, the significant change, as I told you, almost 2/3 of the patients have changed. Next, please. So how does this happen? If you look at the green one, HER2 0, few of them after relapse becomes either low or 1 plus. Few of the HER2 low become actually 0. We all know that receptors do change significantly over a period of time at the time of relapse. This is a fact. This is what is the biology of the disease is. So it is equally important for us to understand that if it is, even if it is HER2 0, it is worthwhile doing the repeat biopsy. And if it is 1 plus or 2 plus, don't shut your eyes towards the HER2 targeted therapies. Keep them open. Why? I'm going to come to that point. Please, next, please. This trial, next, please. This is what actually is the molecule we are going to talk about. That is antibody drug conjugate. We all know antibody that is having FC and FAB moieties. One will find the receptor and bind to it. The second one carries the payload or the chemotherapy on top of it. So you have antibody, whatever target it is going to do. In this case, it is going to be HER2. So it gets internalized, and then FC effector function always will be there. That's the first part. The second part is a linker. There's something called DAR. What is the meaning of DAR? So drug availability on the receptor sort of thing. I can put 10 drugs or 20 drugs or 3 drugs or 4 drugs. That is different. So the linker is a very, very important portion of this. discussion part. And then you actually load the chemotherapy drug on the antibody. It's called payload. How it is going to function? Next, please. So this is going to have a different functions on these things. So if you look at the antibody target of TDM1, again, all of them, so they are HER2s, whereas it is ciclizumab, it's going to be TROPO2. And antibody here is trastuzumab, there it is going to be HR57 human immunoglobulins. The linkers are different. If you look at the payload, the older ones have almost 3 to 4, that's 3.5 on an average, compared to almost 8 chemotherapy molecules can be loaded on top of the newer ones. That is T-Dxd as well as the new one, ciclizumab. And the drugs in the initial we put emetosine, later ones we put SN38 in ciclizumab as well as you put deruxtecan in the T-Dxd. This is what actually makes these molecules unique. And next slides will explain how the drug is going to go into the body and then just deliver its function. Next, please. So the older ones, TDM1, so it just binds, tries to get internalized slowly, and then its release mechanism is tough because the target is linked in such a way that it is not going to get released so fast. Next, please. This is what it happens. So you have the bystander effects. So because of the drug being available, if you look at the newer ones, that is the T-Dxd, so it gets completely internalized and it just delivers the drug like how it lyses and then just makes the drug available into the cell, and it's going to have the bystander effects as well. Next, please. The HER2 positive and hormone receptor positive and HER2 negative metastatic breast cancer landscape. I'm going to discuss just, excuse me, sorry, as I told you, I have one short call to take. I'll keep 1 minute mute and then just join back. Stay with me, please. I'm getting one call from the hospital. Sorry. So sorry for keeping on hold. Next, please. So what are the standard guidelines? The recent updates, whether you look at the ESMO or NCCN says, if it is a first line, you always use any endocrine therapy of your choice, but letrozole, anastrozole, letrozole, anastrozole, or you can use astramustina. Sorry. So to start with, we should always go for the letrozole, anastrozole, or astromycin. And current things, we are always adding CDK4 inhibitors. Either it is going to be palbociclib or ribociclib. This is what we are doing in most of the cases. Once upon a time, based upon the Bolero study, we used to add everolimus in these cases. But nowadays, it is not that fashionable now. In case of PI3K mutations, we always add alpelisib. Good drug, but maintaining sugars is always an issue. If germline mutations are there, you add PARP inhibitors. And if it is showing any resistance pathways, you will be always using elacestrant. And in case if it is HER2 low, that's where the new guidelines are coming into the picture. They say to add TDX as the first line therapy. And in any case, you can always give chemotherapy because that's one that actually works well in the vaginal crisis. And PARP inhibitors, if he's not a candidate for endocrine therapy, you can always use it if the patient is positive for the BRCA mutation, either germline or something. Next, please. So the emerging data that indicates that post CDK4/6 inhibition along with endocrine therapy, ET-based regimen further is not like if I use letrozole, fulvestrant didn't make a big dent into. If I already used one type of therapy, the other type of therapy is not actually making a big difference. This is what actually is making us to think what next. Next, please. So this is the data that we get it. With no established treatments for the hormone receptor positive metastatic second-line standard of care, the comparison between the T-Dxd and the chemotherapy happened. The arms are well balanced. Next, please. So if you look at the patient demographics, they are very well balanced between these two arms. Next, please. If you look at the prior therapies, they are almost similar in these things. Next, please. If you look at the median number of lines of therapy, the T-Dxd arm actually faced a tougher challenge compared to this thing. But overall, no big difference. Next, please. The T-Dxd improves the median progression-free survival as well as overall survival compared to the chemotherapy as well. So this is because the drug is delivered precisely, having a very manageable side effects. We'll come to the side effects in a later point. But the amount of delivery into the tumor cells is much higher compared to the other parts. Next, please. So it not only progressed the PFS as well as overall survival, it did it across all cohorts. Next, please. So if you look at the hormone receptor positive, almost close to 50% of the patients have significant improvement compared to the 16% in the chemotherapy arm. So as the case with the HR negative as well as. Next, please. And across all subsets, it performed well. And the T-Dxd is actually performing much better than the chemotherapy arm alone. Next, please. The nausea, vomiting, and other side effects are also comparable in all those things. Only thing is pneumonitis. You should be always watchful about it. Keep taking good history. All including the grade 5 cases were reported in T-Dxd in the Destiny Breast 04 study. That is only one thing that actually worries us. So when you start the therapy, do a pulmonary function test, understand the history of interstitial lung disease, pre-existing smoking history, and then choose your patients judiciously so that they don't suffer from the ILD. Next, please. So adding to the fragmented second line space in the patients, what is the role of TROP2 targeted antibody drug conjugates? That is Siglizumab, what we discussed, that is S3. Again, the trial design is very similar to what we have seen. Next, please. The arms are well balanced. It also prolonged the PFS and OS significantly compared to the comparative arm, that is chemotherapy. Next, please. So it improved regardless of the TROP2 expression level. That's the beauty of it. As long as it is there, the drug can be delivered into the tumor cell. That's what is the take-home message from this busy slide. Next, please. So the PFS and OAS by the HER2 expression status. If you look at it, the graphs are quite well, we can say separated in HER2 2+. Okay, compared to those, they are not that widespread in 0. Okay, but still it is working. But the graphs are not as widespread as in at least 1+ and 2+. Next, please. But there is a retrospective analysis. If you look at the toxicity profiles, they are quite manageable comparable with the chemotherapy alone. Next, please. So the last part of it, that is metastatic TNBC treatment landscape. So TNBC is no more TNBC. Next, please. We always look into whether it is expressing PDL1, whether it is expressing germline BRCA, whether it is having androgen receptors. We have subclassified them into multiple other things, right? So the actual treatment that is recommended is in the beginning, when the PDL1 is negative, you go with chemotherapy alone. If it is positive, they ask us to add the immunotherapies. If it is BRCA, PARP inhibitors always come into the picture. Second and third line onwards, it is always a challenge. But what you see in the yellow color in the center of the slide is if it is by chance 1 plus and 2 plus, in older classification, if you call it as a triple negative, then T-Dxd is having a significant role in these things. Next, please. So again, so if you look at the subset analysis of the Destiny breast 04 study, it improved the median progression-free and overall survival in patients with hormone receptor negative HER2 low. So that means we used to call them as triple negative, but actually they are HER2 low category. The graphs are wide apart, so beautifully separated, both PFS and OS, that you tend to always do the HER2 1 plus and 2 plus in every patient. That's what is the beauty of this molecule as well as the study. Next, please. If you look at the overall response rates in positive plus negative, this we already discussed. Compared to chemotherapy, did really well. Next, please. So again, the top two in this subset, how did it fare? Again, it's the same 1:1 randomization. Next, please. The endpoints are PFS OS. So this again in the subpopulation also has prolonged the PFS and OS in almost all these patients. Next, please. Side effect profiles, same. It's a repetition of the previous slide only. No major differences. Whether they express the TNBC hormone receptor positive, the side effects remain the same. It is a class specific. Next, please. So to conclude, what to do? Next, please. Henceforth, when HER2 is reported not 3 plus, if it is 2 plus, kindly open the eyes to see whether we can upgrade them into the 3 plus by using a fish. Again, the pembrolizumab and trastuzumab do have a role in there also. But if it is 1 plus or fish negative, please be open for the T-Dxd as one of the options. Next, please. It is not that what I say, all the global guidelines say that the T-Dxd is significantly improved. It's a category 1 recommendation. Next, please. So second line onwards. Next, please. Even in invasive breast cancers, you can always go for the same things. Next, please. So historically, HER2 status was viewed on the basis of binary, positive, negative. But we need to look into the low, positive, or negative. That's the one thing that came in between, and that is a big chunk. Previously, HER2 negative, 2/3 of them are HER2 low positive. So you are offering them some significant and meaningful extra life in terms of PFS and OS. The treatment landscape is changed. The new drugs, especially ADCs, have actually changed. Two drugs, SG as well as T-Dxd, did actually change. Both of them are acting through two different mechanisms, but impact is very, very significant. The two landmark trials, whether it is Destiny or Tropic-02, have changed the PFS and OS in a positive note in most of these patients. Next, please. So this is a drug package set, I think, which you can get from the AstraZeneca on request. Next, please. Next, please. Next, please. This is what actually about the topic of what we used to think as HER2 negative is not actually HER2 negative. Thank you very much. The questions, I guess, we'll just take at the end of these sessions, right?
Suresh sir, thank you for that excellent talk, and you have taken us through the importance of HER2 and the drugs available, the newer drugs available in the HER2 low disease. That was an excellent talk, sir, and I thank for that. And now let me invite Dr. Harshavardhan, who will be talking about the side effect profile of the T-Dxd, and he is a medical oncologist from Hyderabad. So I would like to invite him for his talk. Dr. Harshavardhan, please. Yeah.
Yes, sir. Good evening, sir. Thank you for the introduction, sir. And shall I share the screen?
Sure, sir.
So Good evening, everyone. See, generally, as a medical oncologist, as not only about the PFS/OS, when it comes into the practice, we'll generally more concerned about the any drugs comes into the market. We'll more concerned about the adverse events with the new drugs. That is today topic of the discussion is trastuzumab deruxtecan. So my topic is identification and management of adverse events with trastuzumab deruxtecan. My next 15-20 minutes, I'm going to discuss the what is introduction about trastuzumab deruxtecan, evidence and safety of T-Dxd, and management of adverse events. We should remember these are the main adverse events we are going to deal with. These are the most common adverse events. That is nausea, vomiting, hematological toxicities, alopecia are the three most common side effects of trastuzumab deruxtecan. And adverse event of special interest is interstitial lung disease. I think more of the all medical oncologists, they are more worried about this interstitial lung disease, which is a dreaded complication, and the left ventricular dysfunction. So after the introduction of trastuzumab, treatment landscape of HER2 positive breast cancer had changed. Over the time, multiple drugs are introduced. T-Dxd is introduced, got approval in 2019 as a beyond second line. Post TDM1, it was approved for metastatic breast cancer, HER2 positive MBC. And later in 2022, it got approval for as a second line after trastuzumab and taxane, post trastuzumab and taxane as a second line, and later got accelerated approval for HER2 low MBC. And this was beautifully discussed by Suresh sir, the structure, what is the key attributes of the structure and the mechanism of action. So efficacy and safety of trastuzumab deruxtecan was evaluated in Destiny Breast 3, which is a phase 3 superiority trial. The patient inclusion criteria was unresectable metastatic HER2 positive breast cancer that has been previously treated with the trastuzumab and taxane, and stable brain mets were allowed. And the exclusion criteria, which is very important, that the exclusion criteria were history of ILD or pneumonitis requiring steroids, or ILD or pneumonitis at screening. And any history of clinically significant cardiac disease were not included, and active and untreated brain mets were not included. And any patient with ECOG performance status more than was excluded, and prior treatment with any anti-HER2 ADC in the metastatic setting were also excluded, which randomized to T-Dxd and TDM1. Primary endpoint was PFS, OS, and secondary endpoints were ORR and duration of response and safety. So you can clearly see the beautifully curves are separated. With the 12 months PFS rate is 75% to 34% with hazard ratio 0.28, which is statistically significant. And second endpoint was OS, which is also curves are separated with 12 months OS rate 94% to 85% with hazard ratio 0.55, which is statistically significant. 4 out of 5 patients demonstrated a response, and 1 out of 5 had complete response with T-Dxd. That means overall response rate was 79%, and 21% of the patients had a complete response with T-Dxd. And evidence and safety of trastuzumab deruxtecan, as per Destiny Breast 03 trial, median treatment duration was given as 14.3 months for T-Dxd, and compared to 6.9 months for TDM1. Although the rates of any TEAEs and the TEAEs of grade 3 more than grade 3 were generally similar between the arms, exposure adjusted rates were actually calculated when there is a risk is constant, and the which is if the patient is exposed to more time, there is a chance of having that side effect is more compared to the patients who are on lesser duration. So to avoid that bias, we'll take exposure adjusted rates, which is actually lower with T-Dxd compared to TDM1, and the discontinuation rates also comparable. Exposure adjusted rates were similar, 0.12 to 0.11. And the most common TEAE associated with treatment discontinuation was ILD pneumonitis, which was around 8.2%. And most common TEAs associated with dose reduction were nausea and neutropenia, 6.2 to 6.2 and 3.5% respectively. And most common side effects were gastrointestinal, hematological mainly. Those are nausea, vomiting, constipation, transaminitis, diarrhea. And hematological, next to the gastrointestinal side effects, those are neutropenia, thrombocytopenia, and anemia. And the adverse events of special interest, like I already discussed, 8.2% of the patient discontinued treatment due to the ILD or pneumonitis. And coming to the LVF decrease, all reported adverse events of LVF decrease were asymptomatic, and no cases of cardiac failure occurred with T-Dxd. And today's main topic of discussion is management of these adverse events. Management of adverse events may require temporary interruption, dose reduction, or treatment discontinuation of trastuzumab deruxtecan, but do not re-escalate the T-Dxd dose after dose reduction. So once dose reduction is done, we should not re-escalate. So the starting dose will be 5.4 mg per kilogram, and first dose reduction will be 4.4 mg per kilogram. Then second dose reduction is 3.2 mg per kilogram. But we should not reduce the dose or use after that. If there is a requirement in dose reduction, we should discontinue the treatment. And effective collaboration across MDT helps to optimize the treatment pathways for patients treated with T-Dxd. Before itself, we should decide, we should take the pulmonologist and cardiologist opinion to assess whether patient is fit for the treatment or not. So multiple factors must be considered in treatment decision making: efficacy of the drug or patient choice, quality of life, comorbidities, safety, and patient supporting care. So patient counseling is paramount important, which include discussion on the risk of T-Dxd related AEs and patient education on monitoring for signs and symptoms of T-Dxd related AEs, and encouraging patients to promptly report symptoms so that we can act early. In addition to patient education, there are a range of steps that can be taken proactively to mitigate the potential adverse event that we most commonly generally use with any chemotherapy related side effects like nausea, administration of antiemetics, GCCF prophylaxis for neutropenia, or any prophylactic antihistamine, DEXA, or hydrocortisone injection for infusion-related reactions, or scalp cooling for alopecia. Even though there is no data to support it, we can use it like any other chemotherapy-induced alopecia. And fatigue, we can assess with a clinical history. And ILD also will follow clinical history. Signs are very important so that we can assess. And decreased LVF, assessed LVF before starting the patient on T-Dxd. And the most common side effect is nausea and vomiting, which is around of any grade is around 77% of the nausea and 52% of the patient had vomiting. So it labeled as anti-fam trastuzumab deruxtecan as labeled as a parenteral anti-cancer agent with high hematogenic risk as per NCCN guidelines. So we'll follow like anti-emesis prophylaxis like any other drug with high hematogenic risk, like adding NK1 receptor antagonist, aprepitant or fosaprepitant on day 1, and 5-HT3 receptor antagonists like ondansetron, granisetron, and dexamethasone. Day 2, day 3, day 4, we use dexamethasone, and if already aprepitant oral used, then we will use aprepitant on day 2, day 3. We can add olanzapine, or we can use olanzapine as a breakthrough nausea and vomiting. And other agents for breakthrough nausea, vomiting are benzodiazepines like lorazepam, or metoclopramide, or we can use phenothiazines like promethazine. Or we can, if at all not used before, we can add steroids or 5-HT3 receptor antagonists. If nausea and vomiting controlled, we can continue the breakthrough medication. If it is uncontrolled, then we have to reevaluate and adjust the medication which is not used before. And once the nausea vomiting settle, for the next cycle, we should consider antiemetic therapy at a higher level when compared to the previous cycle. Same only discussed here. So, but one institution study showed which had 10 patients treated with T-Dxd, adding NK1 receptor antagonist resulted in decrease in nausea vomiting to the antiemetic regime. So, NK1 receptor antagonists are an important part of the antiemetic regime. Along with the clinical management, nausea, vomiting, we should advise the patient to mitigate any steps to follow to help the control nausea, like eating small meals or avoid foods that can cause nausea, or sit upright or head raised after hour of meal, and eat food at room temperature, drink plenty of water, and seek dietitian opinion or any alternative treatment. If it is not uncontrollable, then you can alternate treatments like relaxation techniques, acupuncture, hypnosis, and to help manage vomiting, to lie on site to prevent the aspiration, and try frozen liquids such as ice chips. And if there is any trouble swallowing or anything, then they should immediately call the healthcare provider. And the second most common side effect is hematological toxicities. That is across multiple, in patients treated with T-Dxd in clinical studies across multiple tumor types. Neutropenia was reported in 34% of the patient, and 16% had grade 3 and grade 4. Median time of onset was 43 days. And even it can start from day 1 to 24 months. And median duration of first event was 22 days. And febrile neutropenia was reported in 1.3%. So prior to each dose or starting HER2, we have to check the complete blood counts. If there is a requirement, we should interrupt the T-Dxd dose. So most common hematological more than grade 3 toxicity is neutropenia. So for grade 3, interrupt T-Dxd until resolved to grade 2 or less, and then maintain the same dose. For grade 4, interrupt T-Dxd until resolved to grade 2 and reduce the dose level by 1 level. For febrile neutropenia, interrupt T-Dxd until it is resolved and reduce dose by 1 level. So prophylactic treatment with the GCSF can be considered. And a range of medical interventions can be considered to help manage hematological AEs. That is commonly we do for anemia, leukopenia, thrombocytopenia, like iron supplementation and transfusion support, and adding apoptotin alpha or darbepoetin for anemia, and for leukopenia, colony stimulating factors, and for thrombocytopenia also giving platelet transfusion and T-Dxd dose reduction, and avoiding the procedure which have a chance of bleeding. And coming to the overall outlining management for anemia, grade 3 anemia, delay dose until resolved to grade 2 and maintain the dose, same dose. And grade 4 anemia, delay dose until resolved to grade 2 and reduce to dose 1 level. For leukopenia, this is very important. For grade 1 to 3, no dose modification is required. For grade 4, delay dose until resolved to grade 2. And if it is resolved less than 14 days from day of onset, then maintain the same dose. If it is resolved, it will take more than 14 days, then reduce to dose level 1. For thrombocytopenia also, for grade 3, we should watch that if it is resolved less than 7 days from day of onset, then maintain the same dose. If it is resolved to more than 7 days, then reduce to dose level 1. For grade 4, we have to reduce to dose level once it is resolved. Alopecia, although the rates of around 40% chance of any grade, but grade 3 is less than, more than grade 3 are equal to, grade 3 is less than 1%. So alopecia, common HER2 related, that can impact patient psychological and socially. But scalp hypothermia limits blood flow to the scalp and may help block the effects of HER2 on the hair follicle. Although there is no current data to support scalp cooling for HER2 related alopecia, there are studies are ongoing. So like any other chemotherapy induced alopecia, we can add pre-infusion, we can start scalp cooling initiated for 20 to 45 minutes. Then while during the infusion also will continue. And after the post-infusion, we can add agents like minoxidil to help the hair to regrow. And the interstitial lung disease, this is the most dreaded complication. Everybody is also concerned about the same complication. So in patients treated with T-Dxd in clinical studies across multiple tumor types, ILD occurred in 12.2% of the patients. Most ILDs were grade 1 and grade 2. Grade 3 cases occurred in 1% of the patient. No grade 4 cases occurred. And median time to first onset was 5.5 months. This is very important. And cases of interstitial lung disease have been should be evaluated by radiographic imaging, preferably CT, and consultation with the pulmonologist to be taken. And we should monitor patients for promptly investigate the signs and symptoms of ILD like cough, dyspnea, fever, and new worsening of respiratory symptoms. And we should counsel and raise awareness about the side effects of, especially about the pneumonitis to the patient, and ask them to inform as early as possible when they develop these kind of symptoms. And coming to the how we manage the T-Dxd related ILDs, First, we should, if there is any suspected case of ILD, interrupt the drug immediately and rule out if patient developed any radiographic changes or not. And we should also rule out the other causes of the any respiratory infections also we should rule out. And step 2, to confirm evaluation should be include like a high resolution CT and pulmonology consultation to be taken. And if there is a any doubt is there, then we should do bronchoscopy and bronchoalveolar lavage to rule out the infection, and PFTs or pulse oximetries to be done. And if there is a clinical indication is there, we can do arterial blood gases. And drugs must be interrupted as soon as we got a doubt about the ILD. For any grade 1, monitor closely for 2 to 7 days and consider follow-up imaging in 1 to 2 weeks. And consider starting systemic steroids of 0.5 mg per kilogram prednisolone and gradually taper over for at least 4 weeks. If the patient is asymptomatic while on steroids, we should not consider it as a grade 0. We should consider it as grade 1 only. Only after the stoppage of steroids, if the patient is asymptomatic, then we can think of restarting the patient on T-Dxd. From grade 2 and above, we should not permanently discontinue the T-Dxd and promptly start the patient on treatment with systemic steroids 1 mg per kilogram at least for 14 days, then followed by gradual taper over at least 4 weeks. Monitor symptoms closely and re-imaging as clinically indicated. If there is a worsening, we can increase the dose of steroids or we can give IV methylprednisolone. For grade 3 and 4, hospitalization is required. Promptly initiate empirical high-dose methylprednisolone IV treatment, that is 500 to 1000 mg per day for 3 days, followed by at least 1 mg per kilogram per day of prednisolone for at least 14 days, followed by a gradual taper over at least 4 weeks. And if there is still no improvement after 3 to 5 days, we should consider about other etiologies like infection. So before starting the T-Dxd treatment, we should check the baseline lung function, identify any risk factors and comorbidities which can be like history of ILD, smoking, if there is any history of smoking or COPD, and perform thorough physical examination, pulmonary function test, and we should consult pulmonologists as need to discuss the risk-benefit ratio. While on treatment with T-Dxd, these are also very important. Consider routine scans every 8 to 12 weeks and PFTs in between every 4 to 6 weeks. And oxygen saturation to be done at each follow-up visit. And if there is any doubt, we can do a walk test to confirm if there is any drop in the oxygen saturation. And if there is a evaluate for ILD, if the patient developed any symptoms, new or worsening of the symptoms. And encourage the self-monitoring of new onset cough or change in exercise tolerance. Ask patient to call immediately to the hospital. So coming to the next side of his left ventricular dysfunction, even though the LVDF decrease was reported in 36 patients, that is around 3.8%, which were grade 1 and grade 2. And there very less were 0.5% were grade 3. The observed these LVEF dysfunction, most of the patients were asymptomatic, and there is no discontinuation of the drug due to the LVEF. So we should do the baseline echo along with the strain imaging to rule out any LVEF dysfunction. Then initial flow follow-up echocardiograms are commonly repeated every 3 months like other HER2 targeted therapies. In the case of LVEF decrease, T-Dxd, if it is more than 40%, less than 40% of the LVEF or absolute decrease more than 20%, we should discontinue the T-Dxd. And the involvement of the cardiologist can provide insight into the risk stratification. So any patient after starting T-Dxd, if there is a LVEF decrease to more than 45% and absolute decrease from baseline 10 to 20% only, we can continue treatment with T-Dxd. If LVEF is 40 to 45% and absolute decrease from baseline is less than 10% only, still we can continue treatment with T-Dxd, but we have to assess LVEF assessment within 3 weeks. Absolute decrease from baseline if it is more than 10 to 20%. That is, if LVEF is 40 to 45% with baseline decrease from 10 to 20%, then interrupt T-Dxd and repeat LVEF assessment within 3 weeks. If it has not recovered to within 10% from baseline, then permanently discontinue the T-Dxd. If it is, like I already said, if it is less than 40% or absolute decrease from baseline more than 20%, then permanently discontinue T-Dxd. Or if any symptomatic congestive heart failure patient, then we should permanently discontinue T-Dxd. So on summarizing, ARs are commonly experienced with T-Dxd in clinical trials were mostly grade 1 and grade 2, may be managed through supportive care and dosing strategies. Early reporting of symptoms is essential to implement a robust management plan and optimizing treatment outcomes. Patients should be encouraged to report any symptoms immediately to their healthcare provider. Thank you.
Thank you so much, Dr. Harsha, for that detailed presentation on the side effect profile and how to manage T-Dxd side effects. And thanks a lot for that. So let me go to the next session. There's a panel discussion. I will be moderating the session. And I would like to invite our esteemed panelists for today's discussion, Dr. Harish from Yashoda, Dr. Tejeshwar, Nizams,
Hi, sir.
and Dr. Sumant from CARE, Dr. Srinath from Apollo, Dr. Rohit from Yashoda again, and Dr. Namrata from Omega. I hope all of them are available.
Yes, sir.
Yes.
Yeah, thank you. So let me share my screen. Just give me a minute. So we would be discussing for next half an hour how to manage metastatic breast cancer, especially HER2 low disease, ER/PR positive. So please confirm if my slides are visible and I am audible.
Yes, sir. It's visible.
Yes.
Yeah, good. Thank you. So let us go to a case-based panel discussion, which is a hormone receptor positive HER2 low metastatic breast cancer. So she is a 50-year-old postmenopausal female diagnosed to have a IDCC, grade 2 disease, ER/PR 70% positive, HER2 negative, T2 disease, that is 5 centimeters, node negative. She wanted a BCS, so she was given NSCT, TC4 cycles, underwent BCS, followed by adjuvant radiation therapy and adjuvant hormonal therapy. And her germline, HbA1c panel was negative, and there was lost for follow-up for 5 years. So this lady, so this was in 2017. So 2022, she had a severe back pain, and MRI was suggestive of bone metastasis. This is what we generally expect in a hormone receptor positive disease, getting a bone metastasis after 5 years of therapy. So this is her PET scan. You can see the lung lesion, a pleural-based lung lesion, a huge, it's 5 centimeters lesion, and as well liver lesion, which is like 6.4 into 5.5 centimeters, and multiple lung nodules were there, and as well multiple skeletal metastasis was there. So at this point of time, so what about doing a rebiopsy in this case, or you want to treat as per her previous molecular profile? So let me ask Dr. Harish.
Yeah. Hello, sir. Yeah.
Yeah, Harish.
Always I try to do the rebiopsy whenever someone lost to follow-up and coming after with aggressive disease, especially hormone positive.
Yeah, right. So in your practice, generally, what is the discordance you get from the primary tumor versus the recurrent tumor, like in the hormonal status or in the HER2 status? Okay.
Around 10 to 20%, I can say, from primary versus metastatic site.
Okay, so that's for hormone receptor or for the HER2?
Hormone receptors.
Okay,
Loss of expressions I see most of the cases.
Yes.
And HER2 more or less sometimes, if sometimes 2 plus to start with, become 3 plus. I've seen 1 or 2 cases like that.
Yeah, I totally agree with you. So generally in the literature also they say that it's around 15% for ER positivity, which will convert to ER negative after the treatment, whereas negative becoming positive is only seen in 5% of cases. Whereas on contrary, the HER2 positive, the negative will become positive in almost 15% of the cases, and positive will become negative. negative will become positive in more number of cases, and positive will become negative in only 5 to 6% of cases. So any of the panelists want to add to this? Okay, so actually initial, in 2017, she was not tested for Ki-67. Maybe at the time it was the aggressive disease like that, maybe would have offered the other options like, CDK4/6 in the adjuvant setting. So now in the recurrent setting, she has a ER status of 90%, HER2 is 1 plus, Ki-67 is 70%, and GATA3 positive, which is suggestive of a breast recurrence. So, why it is important to doing a rebiopsy. Even Suresh sir also clearly mentioned, this is a very dynamic marker. This HER2 is very dynamic, and especially when it's a HER2 low disease. So it can, transform to any form. It can become a negative or it can become a positive, which will definitely lead us to take the treatment decisions. So in this slide, you can clearly see the IHC score, the HER2 score will increase from primary to metastatic disease in 40% of the patients, and the HER2 low will become 0 in 20% of the cases. It's more common to have an increase in the intensity after the treatment, the recurrent disease, compared to the positive becoming the negative. The disease which is HER2 0 may stay at the HER2 0 level itself, and HER2 positive clearly may stay there. But this is the area, gray zone area, where it can transform into any kind of disease biology. So the discordance which we have discussed, which is commonly seen with the therapy, we can see here the discordance with the local and the central laboratories. The 80% of the samples which are designated HER2 low in the local laboratory were still HER2 low in the central laboratory also. This is based on the Destiny Breast 4 trial. And 20% discordant what they have seen. Out of them, 90% were 0 in the central laboratory. That means the low positivity in the local laboratory was designated as 0 in the central laboratory. And only 10% of them had a positive disease, even though the local laboratory is suggesting only HER2 low disease. So the results will totally depends on these factors, the biopsy type, sample handling, whole ischemic time, and the time of the assay. All these will they determine the HER2 or the any molecular marker status. So what are the gaps in the current definitions of the HER2? So we know that 0, 1 plus, 2 plus, and 3 plus. So there is no doubt with the 0 or 3 plus, but everything happens in the 1 plus and the 2 plus. It's like a subjective variation of the presentation or the reporting what they do by the pathologists. So this is what we generally face in the clinical practice also. So Dr. Srinath, so what's your opinion? You want to plan the treatment based on the initial biopsy or the rebiopsy?
I would like to do a rebiopsy, sir, which I do in almost all my cases, especially when there is such a gap of 5 years and the patient is lost to follow-up. She's not in regular touch, so we don't know whether she's taken the treatment or not and all that. So definitely prefer a rebiopsy.
So if the rebiopsy is like discordant with the previous biopsy or primary tumor, ER positive was there earlier, now it's ER negative, or it was a HER2 positive earlier, HER2 negative now. So how do you want to change the therapies? You want to treat as a TNBC at the time of recurrence, or you want to consider the primary tumor positivity as also a factor in deciding your treatment?
No, sir, I wouldn't consider the primary tumor thing right now, because it's already I think the biology has changed. That's why the metastasis happened. So I'd rather take this report rather than the primary report.
So you will treat them as a TNBC?
Yes.
Right. Okay. And Tejeshwar, your thoughts on that?
Sir, I'll treat her basing on the current biopsy report. Sometimes it is an heterogeneous disease. Sometimes metastasis can have a different IHC expression when compared to the primary site. But still, even though that heterogeneity is there, I'll still consider treatment basing on the current IHC reports.
Right, I got it. So maybe even the clinical case, clinical presentation also may, will lead us to some decisions. If it is only bone metastatic disease of a long time, even the ER becomes negative, maybe we can consider giving a extra hormonal therapies based on the clinical presentation. And it is like an extensive disease like that, maybe you can treat with the, the repeat biopsy markers. Yeah, totally agree with you. So this is the Destiny Breast 4 study. where the inclusion criteria, why we are discussing today the HER2 low disease means the the introduction of these new drugs, and we have more drugs in hand to treat the patients. So this is the included patients for the breast cancer who has low HER2 disease, either +1 or +2. They should never been positive for HER2 or never taken any anti-HER2 therapy. They should have a progression on the previous chemotherapy or the hormonal therapies. And the exclusion criteria would be who are not eligible for any physician's treatment of choice, or who has any anti-HER2 therapy, significant cardiac disease, or significant comorbidities. So this case, who got lost follow-up for 5 years, now she presented with visceral disease, there is a liver metastasis, there is lung metastasis, and bone metastasis. So Dr. Namrata, so what would be your treatment of choice in clinic for today?
Sir, I would like to go ahead with the CDK4/6 inhibitor along with fulvestrant, sir.
Okay, so still it's a hormone and endocrine sensitive. We consider it as endocrine sensitive disease, and you would like to treat them with the endocrine therapy, and definitely addition of CDK4/6 will give us better PFS and the overall survival. Yes, good. So, and what about this, what about the visceral disease? And do you want to consider visceral crisis to decide the treatment for this combination versus chemotherapy? Dr. Namrata?
Sir, I don't think the patient has any shortness of breath or any elevated blood values, LFT. So only if they're elevated, I would like to go ahead with chemotherapy. Otherwise, CDK4/6 inhibitor with fulvestrant will be.
Yeah, true. So even the studies have shown right choice and all, even with extensive visceral disease also, they respond well to CDK4/6 and hormonal therapy without any much toxicities, and they have a better PFS compared to the chemotherapy. Agreed. So she was treated with a CDK4/6 and fulvestrant. She had a progression in the liver after 8 months of therapy. So now what do you want to do, Dr. Rohit?
Sir, I think at this point of time, this is post CDK4/6 inhibitor progression, right, sir?
Yes.
So there are multiple options. One is probably we could test for PIK3CA mutation. In case if it's positive, then we go for alpelisib. If it's negative, again, we have the current treatment options, like, for example, T-Dxd is one good option which is available, because it has shown a preferably long progression-free survival as compared to any other chemotherapeutic agent. If in case the patient is not affording for T-Dxd, then probably I would consider chemotherapy. Okay.
So what about the ESR mutation testing? Do you do routine practice?
Yes, definitely. If ESR mutation is positive, then probably we have this newer option as Trent, but I've not used it any point as of now, sir.
Okay, so you do for the resistant testing with the PIK3CA, AKT, or PTEN mutation testings, and as well as the ESR mutation testing. If everything is negative, I mean everything is comes wild type, then probably you would treat them with a chemotherapy, right? So she was started on chemotherapy, oral capecitabine, and she had progressed with a new bone lesions within 3 months. So now what would be the next line of treatment? May I ask Dr. Sumant?
Sir, yes, sir. Ideally, at this point, it would be an ideal situation to start on the trastuzumab deruxtecan, because actually the trial itself mentions that the patient must have received at least one line of systemic chemotherapy in the metastatic setting before considering for trastuzumab deruxtecan. So a hormonal agent and one line of chemotherapy, then a progressive disease. At this point, it is rightly apt to give trastuzumab deruxtecan.
Yeah, true. So that's what they have done in Destiny Breast 4 study design. They have taken HER2 positive disease and hormone receptor positive disease, considered, HR positive disease considered endocrine refractory, who are progressed on multiple lines of endocrine therapy. They compare T-Dxd versus the treatment of physician's choice. And the primary endpoint is the progression-free survival for the hormone receptor positive disease. And secondary endpoints included the PFS for all the patients and overall survival for the hormone receptor positive and as well as all the patients. And they have stratified, the stratification factors were whether it's a +1 or +2, how many lines of therapy they have taken, whether it's hormone receptor positive or negative, whether they have taken CDK4/6 or not. So that those are the stratification factors. So in this study, you can see, even I think Suresh sir also discussed this study. You can see the baseline characteristics. It's matching with the, all the parameters are matching. And what we need to concentrate are the region. Most of them belong to the Europe or the Asian region, and equally distributed +1 and +2 disease. All of them had a good performance status. Most of them had a hormone receptor positive disease, and few of them had a brain metastasis. 3/4 of them had a liver metastasis, and 1/3 had lung metastasis. That means almost like 90 to 95% of them had a visceral disease, during this study. And the lines of systemic therapy. So most of them had more than 3 lines, including the endocrine and the hormonal therapies. When you take only chemotherapy, most of them had 1 or 2 lines of chemotherapy for the metastatic setting. And the endocrine therapy, again, you can see most of them had at least 1 or 2 lines of therapies, and 3/4 of them received the CDK4/6 for the metastatic disease. So this study has clearly shown the benefit of T-Dxd compared to the treatment of physician's choice. So you can see the PFS 9-10 months versus 5 months, almost like doubling, and you have a hazard ratio of 0.5. This is seen in the hormone receptor positive low HER2 for patients. And even you take the all patients, like both hormone receptor positive and negative, still the difference stays same, like 10 months versus 5 months with a hazard ratio of 0.5. And clearly it starts, it starts at the end, starting itself, the clear separation of the curves. That shows the, the robust, benefit what we get with this drug. And the secondary endpoint was the overall survival. Again, here you can see around 24 months, 2 years for the T-Dxd, and around 1.5 years for the treatment of physician's choice, and with a hazard ratio of 0.69. That means there is 30% reduction in the risk of death when you use TDX in the HER2 low disease compared to the any chemotherapy or any therapy of the physician's choice. And in all patients also, the benefit still holds good with hazard ratio of 0.69. So with this, we can say that T-Dxd is a very good option with the availability of the drug now in the HER2 positive disease, HER2 low disease, who have progressed on multiple lines of endocrine therapy and as well as the chemotherapy or the targeted therapies. So this is the waterfall plot to show that the responses, most of them had the responses, either it's a +1 or +2 HER2 marker. So, so what about the other options what we have? So, Dr. Namrata, apart from T-Dxd, chemotherapy, the targeted agents for the PIK3CA, mTOR inhibitors. So what are the new drugs? Can you have, your inputs on the sacituzumab?
On sacituzumab, sir?
Yeah.
Sacituzumab govitecan, according to Tropics, they have tried it, but I think that is after 3 lines of treatment.
Yeah.
And it is for HER2 negative, sir.
Yeah.
This can be used
right, true. So I know even we don't have any experience with it, but I have experience with the T-Dxd. I had 2 patients on this. So this is the 2 trials which will compare the options of, the T-Dxd versus the sacituzumab. This is a cross-trial comparison. I know we shouldn't be doing this, but this is easy to understand when you keep this side by side. You see the difference, that is 5 versus 10 months in the HER2 low disease, in the Destiny trial, whereas the HER2 negative and the hormone receptor positive disease, sacituzumab has given 1.5 months, 1.5 months with a hazard ratio of 0.65. So with this, we can clearly say this would be the superior drug when you treat, this biology of the patients compared to the other drug. So what about, this patient has received the CDK4/6 upfront. So what about re-challenging it in the later lines? What's your opinion, Dr. Harish?
So re-challenge so far, I've not tried anyone, but with the available data, I don't think so. We have enough strong data to suggest re-challenge any of the agents, except some phase 2 studies where abemaciclib was shown to be beneficial. Someone who has progressed on the palbociclib. If I'm running after options, then I will re-challenge. Otherwise, I will try to look for the options left, like T-Dxd followed by sacituzumab, followed by maybe. Then in that case, I'll re-challenge.
Yeah, agreed, Dr. Harish. Rohit, your opinion? You will concur?
I would agree with Dr. Harish, sir. Specifically, if we see the magnitude of benefit also, even with the available literature, I think it's very small. In the availability of other options such as trastuzumab deruxtecan, probably sacituzumab, So I would defer it to a later line when I exhausted all the other options.
Yeah, I totally agree. So when you have multiple options in hand, no need to again, do a trial of with CDK4/6 where you can see the benefit is much less. And there is no strong evidence to use it in the later lines once they progress on the same drug. So I totally agree with you. But this is the trials where they have shown some benefit with the, in the maintained study, ribociclib post CDK4/6, that is nothing but a palbociclib. They have shown a benefit with hazard ratio of 0.57, but I think in clinical practice, we are not following the same, the strategy. And in the PACE study, where they have combined palbase with fulvestrant versus fulvestrant alone, post CDK4/6 progression, you can see it's detrimental. When you are using again the palbociclib, it's detrimental. But some benefit was there when you add immunotherapy to that. But these are all, just some, not robust enough to practice them in the routine practice. So what if the patient has a germline BRCA? So I have already told you that, this patient is negative for germline BRCA. Otherwise, maybe now at present would give her the adjuvant, olaparib. But if the patient had a germline BRCA, how do you want to sequence the drugs, Dr. Tejeshwar? How do you want to incorporate PARP inhibitors in the course of treatment?
So basing on the data, the Olympiad trial has shown that in the second line setting, we can use PARP inhibitors in patients who are having a germline BRCA positive. So I don't know that how many patients in the current trastuzumab deruxtecan trial who are having an BRCA positivity. So we don't have a data of till now. I don't think we don't have a data of trastuzumab deruxtecan in this subgroup. So in these patients, I would like to go with an PARP inhibitors. Maybe in the later lines, I would like to sequence with chemotherapy or trastuzumab deruxtecan.
Yeah, totally agreed. Dr. Srinath, your thoughts?
Agree with Tejeshwar, sir. I think we prefer olaparib in the earlier lines compared to deruxtecan, definitely.
Yeah,
I think because it has more targeted activity compared to deruxtecan is my opinion currently with the data what we have.
Yeah. So in the BRCA mutant HER2 negative metastatic breast cancer, we can definitely incorporate the PARP inhibitors where it has given the improved PFS compared to the physician's choice in both the trials in Olympiad and as well as in the BRCA, and with the good hazard ratios. Definitely, it's an option. In the sequencing the drugs, definitely it comes into the picture. So what about Dr. Sumant, your views on will HER2 IHC levels matter in the end for the T-Dxd? And even a clinical practice, do you use a maintenance endocrine therapy once they responded to T-Dxd? And do you continue the endocrine therapy as a maintenance? Who had progressed on multiple lines of endocrine therapy? Sumant, what's your thoughts on this?
Yes, sir, definitely. However, there is no clear-cut line between +1 and HER2 plus ISH negative in the HER2 low population of group. I would still consider that HER2 plus IHS negative would be more responsive. But I won't choose between these two. But it will only guide us whether the patient would respond better or not. And regarding the second question, definitely I would consider opting for another endocrine therapies, as there are multiple endocrine therapies if the patient has to stop trastuzumab deruxtecan due to some toxicity, keeping in view of the good biology of hormone receptor positive disease.
Yeah, Dr. Harish, your thoughts?
Yeah, so I missed that question, sir.
So
Yeah,
do
like
you
regarding
want to
the role of
continue maintenance endocrine therapy? Do you feel it will help the patient?
hormone refractory, definitely not, sir. At least I would like to keep that single agent only.
Yeah.
Hormone refractory setting, I would not continue the therapy, though the side effects may not be much like adding some hormone therapy, but still adding cost or IM injections. I would like to continue single agent rather than adding therapy, especially third or fourth line when they are refractory.
Right. Yeah. So any other panelists, Dr. Namrata, your thoughts?
Sir,
Final
I
thoughts on
agree with
this drug or
Hari
yeah.
sir's opinion, sir.
Yeah, okay. And Rohit?
sorry. So regarding the maintenance endocrine therapy, I'm not sure if it would really add any benefit to the patient, sir, if we have stopped T-Dxd. As in this particular case, I think we have already tried multiple options of endocrine therapy. We are not sure whether any other endocrine therapy will add some sort of benefit. But if it's a hormone sensitive disease, probably yes, maybe I would definitely consider. And regarding the IHC levels, I think in the final results of the Destiny Breast 04 trial also, there was no difference in progression-free survival if it was IHC +1 or +2 FISH negative, sir. So
anyone has, agree. So anyone has any experience with T-Dxd drug?
No, sir, not me.
No, sir.
I had 2 cases. Both of them were like, after multiple lines, desperately we added for a HER2 disease. She has taken 3 cycles, but we lost her with the transaminitis and as well as disease progression. We feel that this is a miracle drug, but I lost that case. And one more case was a HER2 positive disease. Again, she was almost like a 6th line of therapy. We introduced T-Dxd. She had, grade 4 pneumonitis and again, a disease progression along with pneumonitis, side effect. We lost her during the 3rd or 4th cycle. So I have a bad experience with this drug, maybe because the case selection is very bad. That I can agree, and all the studies have shown that that a huge benefit what we see with this T-Dxd compared to the other therapies. Yeah. So with this, I would just conclude that we have today we have discussed the HER2 low disease. What is the importance of HER2 testing? How to interpret it? What is the importance of HER2 low in the clinical scenario? And how to manage these cases and how to sequence the drugs. What are the available newer targeted drugs for this HER2 low disease? And definitely these come into the picture in the clinical practice, if not very common now, but maybe within 6 months or 1 year, it will be like a very commonly used drug like what we are using the TDM1 right now. So with this, I would like to thank once again the organizers for giving me the opportunity and the AstraZeneca. So I would hand over to the organizers. You can take over. If any questions, we are ready. Even panelists are ready to answer.
Thank you so much, sir. So in the Q&A section, we've received a question.
Yeah, Sophia, can you read out to the panelists? So when tumor is hormone receptor positive, why not to keep patient on maintenance hormonal therapy? Anonymous attendee. So that's what the panelists believe. If the patient is already endocrine refractory after taking so many lines of therapies, and we have how many endocrine therapies? We have only 3 or 4, right? We have, aromatase inhibitors. We have estrogen receptor depleters and estrogen receptor modulators. So what kind of a maintenance therapy will help the patient? If anyone wants to give a thought, you can please you can answer. Yeah, endocrine
That's perfect
refractory.
answer, Chaitanya.
Sir.
Yeah. So I mean, it's one quick question. Are there any markers to say that this patient may not respond to the therapy? I'm asking the other way around. I usually, whenever we hear TDX is having a wonderful responses, whether you go for the HER2 climb comparison or brain mets, recently I attended another conference where the Indian consensus were made, where if you see 80% of the times, the entire panel is inclined towards recommending the TDX. That makes the question more curious when not to choose. Of course, affordability is an issue. Let's not discuss that.
Right, sir. I totally agree. Yeah. So once we get used to this drug, I think we'll feel much more comfortable, confident enough to treat and keep it, push it forward in the front lines rather than much later lines, as I have done.
Thank you. So I think we have one more question in the box. So how will you confirm endocrine refractoriness?
Suresh, sir, you can take up that.
Yeah. So it is while the patient is progressing on that, there are a couple of ways. One is a clinical case scenario where if there is a radiological progression that you take it once, despite having a, if you are using I can say AI, you need to ensure that the person is in the postmenopausal range. That's one of the mandates that we always look into it. And second thing is to do a genetic markers level to see whether they are having any refractoriness. That's how you're going to confirm it once the patient doesn't respond to the endocrine therapies. Right?
Right, sir. Right. So thanks a lot, sir, for those valuable inputs. And I would like to hand, please.
Sir, Krishna Chaitanya, sir, that your patient who developed pneumonitis, after which cycle, sir, after how many days did you first notice?
So transaminitis, even first cycle also she had issue, one case, transaminitis,
Okay,
but we, it was like, grade 2. So again, we delayed the therapy, then started. Whereas second case, she developed during the third cycle, the pneumonitis, in between second to third, I can say.
Okay, sir. Okay, sir.
And
the developed patient succumbed to the
Yeah. She had a pneumonitis and as well as disease progression also. She was like on multiple therapies. It was on 6th line. Yeah, she was on 6th line, the HER2 positive case.
Okay, sir. Thank you.
Yeah, thank you.
Thank you. We're logging off, right?
I think there is
thank you,
another
sir. Good
question,
night.
sir.
Good night.
Good night.